You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for July 15th, 2022. This week, we're going to talk about the life study, multimorbidity, real-world translation of evidence, the therapy for sudden cardiac death, therapeutic fashion, diabetes in cardiology, and cuts in electrophysiology reimbursement. First, though, this is July, so it's the Tour de France time. And to my Belgian friends, I want to say how amazed I am by Wout van Aert. And I'm so glad to have seen him race as a junior on our cross course here in Louisville at the 2013 World Championships. Wout has a huge fan club in Kentucky. And to my Danish friends, my family tingled with delight watching Jonas Vingegaard crush it up that final climb on Wednesday. This was such a spectacle of sport. Okay, now to cardiology. I want to start with the discussion of a substudy of the life trial published in JACC Heart Failure. First author, Justin Vader. Now, it's unusual for a substudy to lead the TWIC podcast because here I like to focus on main trial results. But this particular substudy deserves attention. Now, recall that JAMA published the main life trial results this year. Life compared sacubitril valsartan to valsartan in patients with advanced class 4 heart failure and reduced ejection fraction. The main outcome measure was NT-BNP over 24 weeks. Clinical outcomes in life were secondary endpoints of the trial. The main finding was that there was no difference in NT-BNP in the two groups. Neither was there any improvement in clinical outcomes, and what's more, 1 in 5 patients were not able to tolerate the sacubitril valsartan during the run-in, and about a third of patients discontinued the drug during the 24 weeks of the trial. Now, the Vader et al. Substudy focused on the tolerability of sacubitril valsartan during the run-in period. And they found that the reasons for intolerance was A, low blood pressure, B, symptoms of lowish blood pressure but a systolic blood pressure greater than 90, and C, renal dysfunction. Now, they also did a correlation of multiple variables as predictors of intolerance, and they found that low blood pressure, low sodium, having an ICD or CRT, having mitral regurgitation, not being on an ACE or ARB, or use of insulin at the initial visit predicted intolerance. And if a patient had 4 of these characteristics, there was approximately a 50% chance of intolerance. Now, my comments. I lead the podcast with life in this substudy because it speaks to this anointed notion of guideline-directed medical therapy, or GDMT. Well, I've said this a gazillion times on this podcast, but I will say it again. Most drug and device trials enroll ideal patients. Ideal because they often have few multimorbid conditions and decent socioeconomic status. And this is especially true for heart failure trials. Life is special because it took on an advanced heart failure patient, the sort of patient that often has multimorbidity. And it showed with obvious clarity that the anointed sacubitril valsartan drug does not benefit these patients, and many, nearly most, cannot even tolerate it. And once again, this important area of external validity or generalizability of trial results comes up. And I don't have data on this, but I suspect from practice that most sacubitril valsartan gets started in vulnerable patients with heart failure in the hospital. And this, of course, is driven by GDMT. You know, the get with the guidelines near religious drive to practice evidence-based medicine. Yet this evidence comes from stable, ambulatory, mostly male outpatients with heart failure. They're good enough to walk into a heart failure clinic. The LIFE trial, and its run-in periods, and this study reminds us that multimorbid patients with more advanced heart failure likely do not benefit from sacubitril valsartan. It reminds us with utter clarity that translation of evidence means going to Table 1, the patient characteristics of these studies, and looking at the paragraph on inclusion and exclusion criteria and asking the question, who were these patients in the trial from which this evidence came? Finally, the other point to make here concerns the notion, this idea that higher risk patients stand to benefit more from interventions. This idea is more often than not a false idea. Life shows so perfectly that patients with multimorbidity or advanced organ failure do not garner the same benefit of those well enough to stroll into an outpatient heart failure clinic and get enrolled in a trial. And if you don't believe me on the concept of higher risk patients benefiting less from common therapies, go look up the GCHF and Corona trials of statins in advanced heart failure, or go look up the Aurora and 4D trials of statins in end-stage kidney disease patients. All 4 of these trials studied super high-risk patients, and all 4 trials showed no benefit from statins. From statins. Okay, next topic, resuscitation. What is up with resuscitation science? This field seems to overflow with RCTs. JAMA has published yet another RCT called the multicentric EMERGE trial, looking at the use of emergent versus delayed coronary angiography in patients who survive cardiac arrest and do not have ST elevation. The whole notion got started from an uncontrolled case series of 84 patients published in New England in 1997. This study found that half of the survivors had a coronary occlusion, and about half of those had successful plain old balloon angioplasty. And when they did regression analysis, i.e. correlation, they found that successful angioplasty predicted better survival. Of course it did, but the confidence intervals in that uncontrolled paper went from 1.1, which is almost no benefit, to 24x. Okay, early angiography makes sense because cardiac arrest often stems from plaque rupture and total occlusion. But before this French EMERGE trial, which started in 2017, we have seen publication of not 1, but 3 trials testing early versus late angiography in survivors of cardiac arrest without ST elevation. The Lemke's et al. In New England Journal 2019, no significant difference in survival. Kern et al. Circulation 2020, terminated early for futility. And Desch et al. New England Journal 2021 reported a trend for higher mortality in the early angiography group. Certainly no benefit. And now EMERGE, guess what happened? No difference. Again. Okay, comments. First, any ongoing trials in this space should stop. And for patients with cardiac arrest and no ST elevation, the strategy of immediate angiography should stop. We have enough data. I think we should just change practice. My question, and this is a real question, I don't know, is why do we have 4 trials testing a strategy in this condition? And often we have 1 or none in other strategies. In other words, why has the therapeutic fashion of coronary angiography become so ensconced that it takes 4 trials to de-adopt this for this condition of cardiac arrest without ST elevation? Now, as a matter of contrast, think of the anointed therapies that we accept with 1 or even no trials. Sacubitril valsartan again in heart failure with reduced ejection fraction. Paradigm HF, which the drug beat a medium dose of enalapril. All other sacubitril valsartan versus stronger ACE inhibitors like ramipril or valsartan have yielded non-significant primary endpoints. We have 4 trials for immediate angiography in cardiac arrest and 1 for a drug we spend billions of dollars on. Sorry, another example, Watchman for stroke prevention. Now we know Watchman did not meet non-inferiority versus warfarin for the primary endpoint of stroke and systemic embolism and PREVAIL, the regulatory trial. So we extrapolate that unimpressive data to patients who cannot or do not want to take oral anticoagulation. Yet these patients were excluded from the trials. So we have an utterly preventive procedure done every day with significant risk of major complications, and yet we have not a shred of data to support its use. And don't tell me about PROG 17 because that trial does nothing to change my pessimistic priors. And in my field, AFib ablation, one of the main financial engines of electrophysiology, We don't even know the cause of atrial fibrillation. We don't have convincing evidence the procedure reduces heart outcomes. Remember, Cabana was non-significant. And there are 0 published sham-controlled studies looking at quality of life of AFib ablation. Stents in coronary disease, stable coronary disease. Here the case is different. Here we have oodles of data showing that revascularization added to OMT, optimal medical therapy, does not reduce MI or death. And it probably doesn't improve exercise time against the sham control. And we, for the most part, ignore the results. Now, worry not. I'm going to make a point here. But first, I want to refer you to a shocking paper. Shocking paper. This was published in April. One you won't see covered in the media. The Journal of Clinical Epidemiology published this systematic review of over 1,500 interventions in biomedicine. And I'm going to link to this paper. The authors took this large random sample of interventions that had Cochrane reviews. Now, if there's a Cochrane review of something, it's likely to be a common intervention that has a bunch of studies. The first author of this paper is Howick, Howick. They wanted to know what the proportion of interventions tested by Cochrane have high quality evidence of benefit. And high quality of evidence of benefit was described as when you use the grade level of reviewing evidence, the primary endpoint had to have high quality, low bias evidence. Second, the primary endpoint had to be statistically significant. And third, the Cochrane authors themselves, who are usually independent, had to conclude the therapy was effective. With this high bar of evidence, guess how many interventions have the highest quality evidence? 5%. That's right. Less than 10% of the things we do in healthcare have robust, high-quality evidence for benefit. Howick and colleagues also looked at harms reporting and found harms were measured in only about 1/3 of interventions. And there was a statistically significant evidence for harm in about 8% of these Cochrane reviews. So my question, therefore, is how can therapeutic fashion become so firmly established? And is this not dangerous? I mean, recall how strong the therapeutic fashion was for treating PVCs after MI. Did you know, for instance, that a British doctor, tried to warn cardiology 10 years before CAST? The CAST trial found that the number needed to kill with antiarrhythmic drugs was 29. So imagine how many lives would have been saved had we been less cocksure of our interventions. I've got a column coming on this topic Monday. In it, I ask you to consider the idea of therapeutic fashion and why and how it occurs, and how we can prevent it. And I ask you, please read that Howick paper. It's open access in the Journal of Clinical Epidemiology. Okay, next topic, diabetes and cardiology. I had a busy few weeks in the lab. I've done vein of Marshall ablation for mitral isthmus flutter, multiple left bundle branch area pacers, ICDs, ablations for SVT, VT, AFib, flutter. But the thing I was bragging most about was changing a patient's diabetes meds. I did it. I was seeing him for an arrhythmia, but he had type 2 diabetes and CKD, and he was on an oral sulfonylurea, not an SGLT2 inhibitor. But he had 2 indications for the SGLT2 inhibitor, diabetes and CKD, so boom, I switched him. Now, I don't understand why we wouldn't use drugs that have been shown in trials to reduce important heart endpoints. But here's the problem. In the US, and maybe in your country as well, there are barriers to use these drugs. Which brings me to a very nice study from a young researcher from the University of Pittsburgh named Utibi Essien, who, with many co-authors, decided to look at the care of patients with diabetes who select Medicare Advantage as their health plan. Now, more Americans are choosing Medicare Advantage. These are offered by private insurance companies that are contracted with Medicare, and they provide at least the same level of coverage of basic Medicare. And they often cost less. But there are trade-offs. There may be less freedom of choice. What Essien and his co-authors found by looking at a diabetes database was that about 1/3 of the nearly 350,000 patients choose Medicare Advantage. And for those in Medicare Advantage, they were significantly less likely to receive glucagon-like peptide 1 receptor agonist, GLP-1 receptor agonist, and SGLT2 inhibitors. And journalist Dr. Mitchell Zoller, he actually has a PhD, has a nice recap of this paper. He notes in his story that diabetic patients in Medicare Advantage did have some upside, though. They were more likely to be screened for nephropathy or eye disorders and more likely to have foot exams. And to me, this is a terrible trade-off, right? You could have screening for disease that may be prevented by taking the drug in the first place, or you could have your foot examined, or you could simply get the effective medicine covered. I like this study. It's very nice work. The main limitation, however, is that drug A or drug B use, or the number screened, or blood glucose, or blood pressure levels are surrogate markers. What we would really want to know is whether patients with Medicare Advantage versus regular fee-for-service Medicare have better or worse outcomes. And to answer this, you need, wait for it, randomization. Yet, not a week goes by that the profit-driven U.S. healthcare system doesn't frustrate me. I mean, if we could figure out a way to reward insurers, payers for better outcomes, perhaps they would be more apt to cover drugs and interventions that have been shown beneficial in trials. I don't know how to do it, but to me, it seems like value-based reimbursement is the wisest choice. Now, speaking of therapeutic fashion, how about the power of treating to the surrogate of hemoglobin A1C rather than using drugs that reduce outcomes in diabetes? There's another one. Okay, final topic is reimbursement cuts coming to electrophysiology. My friends, please, I want to close with a plea to think of us American EP doctors. We have recently endured a 30% cut to our AFib ablation fees. My field has experienced this spasm of palpitations about this. It seems U.S. payers decided that all of that add-on stuff that we do during ablation, use of 3D mapping and intracardiac ultrasound, should now be considered normal, and therefore they bundled these lucrative add-on codes into one code which has a lesser fee. This, of course, has not been received well. But now it's worse. We learn that payers are considering even more cuts to other sorts of ablation and perhaps even the gold mine that is remote monitoring. Now, I get tons of emails from HRS, Heart Rhythm Society. They're basically saying, we too are aghast and will work with policymakers. My translation of this, though, is that they are impotent to change these findings. Professional societies in the U.S. serve many masters, and protecting members' salaries is hardly one of the main ones. I have mixed feelings about this. Of course, it's normal to feel great about what we do in the lab. It's pretty amazing how far EP has come. I mean, we actually can cure patients with focal arrhythmias, and remote monitoring can often uncover important problems with the device before, say, they get a shock. We can pick up AFib and start oral anticoagulation and likely prevent stroke. And you get to feel that these are valuable things worthy of a big salary. That's normal. But, my friends, the payers have a point, too. I mean, we've been using codes for ablation that stem from the days when ablations took many hours. Now, it's normal for an SVT ablation to be over in less than 90 minutes. Same for AFib ablation. And PVI, pulmonary vein isolation, it's not nothing, but it is rote and well practiced, and it's about 10 times easier than doing clinic. And I am not sure there is a more low-value medical intervention than an ILR for AFib detection. I mean, these devices are expensive. We can bill patients super frequently for the remote monitoring. There's way too much fat in a remote monitoring space. Finally, and this is crucial, if you're going into EP for the money, you're making a huge mistake. This is a glorious field. Your knowledge of basic physiology translates directly to the care of a patient. I mean, knowing the action potential of different cardiac tissues explains so many things at the bedside and on the ECG. We get to use amazing curative procedures. Curative. The simple pacemaker, I used to consider banal, and now appreciate as exceedingly elegant. I mean, it transforms patients' lives for the better, sometimes Lazarus-like. In EP, you also get to have a relationship with people, sometimes for decades, through health and illness. Your patients come to trust you. You also become part life coach and psychologist. You have the power to remove fear simply with your expertise and voice. This is meaningful, aka I think it's priceless. So for me, my relative value units hardly matter. They never really mattered. And even with these cuts, we will do fine. We will be okay. And one final thing, some of you may rebut my comments with the fact that EP docs have to train longer. We should get paid more because we train longer. And my response to that is training might be the best years of your life. You should never want to shorten that. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, it goes a long way to writing us a little review. At least give us a rating. And on social media, let's use the hashtag TWIC podcast. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.